Good afternoon from Miami Beach. This is Dr. John Bennett for Neurosurgical TV. We have our third episode of Africa Neurosurgical Grand Rounds, and we're graced with the presence of Omar Antonio Gomez Valdez. He's a Mexican neurosurgeon that got in touch with me and wanted to present. So before I turn over to Omar, let's meet the guest panelists. Okay, Omar, let me just introduce the panelists, okay? Hi, Dr. Joanna, how are you?
Hi, John. How are you? I'm fine. Greetings from Finland.
Okay, she's from Finland. She's from Helsinki, Finland. We're glad to have her. Yes,
that's great.
Yes.
Yeah, it sure is. Okay, Dr. Gabulo.
Hello, everyone. My name is Kabulo. I'm from Democratic Republic of Congo, currently final year neurosurgeon resident at the University of Zimbabwe.
Yeah, he's been with us from the start. Hello, Dwayne. Good day. Dwayne.
Hello, Dr. Bennett. I'm Darwin Chimba, a medical student from Zambia, Copperbelt University.
Yes, and he's going to lead a channel for medical students from Africa to educate them during this time of the corona. Right, Dwayne?
Oh.
Okay, very good. Kennedy, could you please introduce yourself?
Hi, John. You can hear me?
Yes, we can.
Okay. My name is Kimani Kennedy. I'm a third-year neurosurgical resident from Kenya, the University of Nairobi.
Oh, excellent. A friend of Khalif.
Yes.
Very
Yeah, I
good.
know
Well,
Khalif is a friend of mine.
We're welcome. Okay,
Yeah,
very good. Monir, I don't know if you're there. Monir, are you there? Perhaps not. Zolo, you're here, right, Zolo?
Hello, Dr. Ben. Hello, everyone. I'm here. I'm Zulu Ivan. I'm a CTA medical student from University of Buea in Cameroon. It's a pleasure being here. I'm a member of AFAN, and it's an honor to be here with you.
Well, Zolo had an audience with a legend in neurosurgery, Yuha, and he was bold enough to ask him a question. I was surprised, Joanna. Okay, Redme, I don't know what the name is. Redme, are you there? Or Aminata, okay, Aminata, you're there, I'm sure. Aminata, could you please introduce yourself?
Yes, I'm Aminata, a neurosurgery resident training in Zimbabwe, from the Gambia and living in Namibia.
I know, it gets confusing, doesn't it? Okay, very good, welcome. And Rahul, can you introduce yourself, please?
Yeah, hi, John. I'm Dr. Rahul, final year resident from India.
Oh, welcome, Rahul. Okay, very good, Omar. Thank you very much for taking the time to present, and it's all yours. Please say a few words about yourself first, Omar.
Okay, thank you.
Can you say a few words about yourself before you start?
Yeah. Well, I'm a fifth-year resident here in Mexico City from the General Hospital from Mexico. I'm a member of the American Association of Neurological Surgeons and the Congress of Neurological Surgeons too, and a member too of the International Society for interested in pediatric neurosurgery. So I published tumors in children. So, well, now I'm gonna speak about complications of CSF shunting. Hello, everyone, and I'm so sorry about it. Well, I'm Omar Antonio Gomez Valdez, and we are gonna talk about the complications of cerebrospinal fluid shunting hydrocephalus in pediatrics patients. So, next, please.
Okay, I'm sorry, Louis.
So, as we know, there's a lot of diversion procedures to, well, among these most common neurosurgical interventions around the world, and the majority of these procedures are compromised of ventriculoperitoneal shunt insertions. As we know, we have a lot of patients that, well, with the hydrocephalus. So this is a common procedure. So in the United States, the annual incidence of this ventricular peritoneal shunts replacement is about 5% or 5 per 100,000, with almost 30,000 procedures performed each year. And that's why this is very important to talk about it. So next, please. So at 5 years following shunt insertion, we know that the cumulative complications rate at least was reported in general in 33%. And these complications may include malfunction or sometimes caused by obstruction, mechanical disconnection, or another mechanical affection, and sometimes infection on the site or along the trajectory of the shunt, and sometimes over drainage that may cause in some patients even hemorrhages. So this is why it's very important to know this. Next, please. Well, in pediatric population, we have the other one, please, John. Oh, well, that's fine. Well, the factors that are associated with shunt complications, we know that the male sex is used to present this, and we have too low socioeconomic status, younger age, like the newborn, and repeated shunt failures of obstructive, as we know, and low gestational age at the time of the first shunt insertion. Next, please. Good. Will you kindly pass to the other one?
Okay, the next slide or this one? Is this okay?
So, and the heterogeneity in practice and complications. We're going to talk about heterogeneity.
Just hang in there. Sorry, folks, just be patient. Okay. Sometimes the bandwidth will slow things down. Be patient with this technology.
I have trouble with it. Sorry, John.
That's okay. It's okay. Just keep rolling.
Yeah. Well, as we know, the impact of shunt-related complications on the individual and society, it's important to recognize this heterogeneity, because we know that not all the patients had the same kind of two types.
Oh boy. Oh boy.
I don't know.
Sorry, folks.
Happening. One more time. In surgical decision making, that's very important, because as we know, in children there are many iterations or many types of hydrocephalus according to the migration of the neurons and or the cells, And that's why this team is very important, and we must know what kind of shunt we are going to use in these patients, because this is not always the same. Next, please. So in this image, we can see the CSF pathway we have in 5 stages, and we can see in the embryo, in the fetus, then in neonate, and then in infant. There are very variations in the cerebrospinal fluid in these stages, and we must know this because cerebrospinal fluid will change according to the age of the patient, and according with this and another things in these patients, we're gonna choose what kind of shunt we're gonna use. Next, please. So in general, there's no consensus on the optimal methods of cerebrospinal fluid diversion, and the specific devices, procedures, and other protocols that we know should adopt uniformly to decrease the risk of shunt-related complications. What? Well, in patients who require an insertion of a ventriculoperitoneal shunt, we know that there are a lot of non-modificable factors that may predispose to subsequent complications. Rarely, we know that the pediatric patients had an, how can I say it, it's not complete the immune system, and they have a lot of predisposition to get an infection or sometimes an obstruction. Oh, did you go out from the slide? Jim?
I'm sorry, I lost the PowerPoint, I'm sorry. Production problem. Hold on, folks. Now I had your PowerPoint, I'm sorry about that. We're making all kinds of, we're making all kinds of.
Yes, Dr. Ben, just open the PowerPoint, click on it, shunt
Let me
dysfunction
stop
PowerPoint.
share. Hold on, folks. I gotta go back to your PowerPoint.
Yep.
That I got from you. This is part of learning, folks. Learning on the job. Yeah, I got to. Oh, you sent it by email. Oh my God. Yeah. Okay. Yeah. Okay.
So sorry for this.
No, that's all right. It's just part of learning. You know, wow, your email disappeared. The email doesn't have the attachment now. Okay, hold on.
Okay.
Oh, you gave me two. Okay. You gave me one there. Okay, there we go. Okay. We're back on track. Okay, let me share this and then we'll be ready to roll. Okay.
Okay.
Okay. Let me get to the 6th slide, I believe it was.
Yes, and Dr. Ben, if possible, could you click on the last icon to your bottom right? Yes.
The slideshow?
Yes, Dr. Ben.
Yeah.
Oh, good. Oh, excellent. Thank you, Solo. That's why we pay co-producers.
Yeah.
Okay, go ahead. Oh, okay, which slide? Am I on the right slide?
I think that we were on the 7th.
Okay, you know, Zolo, I can't see the slides from here. Okay. Tell me when to stop. Tell me when to stop.
Okay. I'm gonna tell you. Next one. I can see it. Huh? I can see it. I'm just saying heterogeneity in practice and complications. That's all that I.
Are you seeing? You're not seeing the PowerPoint?
Yeah. Next slide.
Okay.
I can see it, and I'm just
You can't even see
watching the 5 one.
Can you guys see the PowerPoint?
It's not changing. It's stuck on one.
Yeah, it's not changing.
One page.
Okay, I'm changing it, but you're not seeing the change.
Nope.
No.
Okay. Let me restart it again. Stop share. And I'll reshare it and see. Okay, do you see it now?
Okay.
It's far better. Thank
Yeah.
you.
Come back to. Go to one. Yeah. Before.
Forward or back?
Oh, back.
Back.
Yeah. Back again. Okay. Here we are. So, I'm going to continue. So, heterogeneity also exists, like we know, in the underlying pathological conditions in this kind of patients. So, these are going to lead to shunt-dependent hydrocephalus. Not all the patients will have these ventricular shunts for his life. And next one, please. So this is very important. They may range from congenital malformations, and such as an aqueductal stenosis or another variations, like the patients who have myelomeningocele, as we know that they used to have hydrocephalus with this. And it's very important to know these underlying etiologies of hydrocephalus. So with this may be independently associated with poor outcome or poor health related, and they are going to have another kind of complications according to the first etiology. Next one, please. So these malformations or alterations, we have part of a neural tube defect, as we know. The encephalocele and myelomeningocele are associated with hydrocephalus, and the other ones are part of a central nervous system malformations like Chiari-2, Dandy-Walker malformation, and all their variations. For example, we know that the Dandy-Walker malformation had a lot of malformations associated, and if we have another one like the holoprosencephaly and iranencephaly who had a bad. Well, next one, please.
Hold on. Okay.
Yeah.
There we go.
And the final one, the congenital aqueductal stenosis, that may associated with an X-linked hydrocephalus and autosomal recessive and dominant forms. And the last one, the communicating hydrocephalus and all their variations in these patients. Yeah, next one, please. Next, please.
This one, next one?
Yeah, next one, please.
Okay.
That one. That's good. I'm put this in this presentation because I think that it's very important to know all the midbrain and hindbrain malformations, because we, at least in my country, we saw a lot of patients with Dandy-Walker malformations and lissencephaly who had only one shunt, and we know that this will be very difficult to abort. We know that we can use sometimes two kind of catheters in supratentorial or infratentorial to avoid these patients, because we know that in Dandy Walker, for example, they have another cyst collection, and the pressures will be different in this patient. So the valve or the shunt that we are going to choose will be different if we found another patient with, for example, tetraventricular hydrocephalus. This is very important. We must know in these patients all these variations or malformations, and we must know what kind of pressure in the valves or the shunts we're going to use. Next one, please. Next. So on this image is just to represent another malformations. For example, we had these images of an enlargement of fetal pericerebellar CSF spaces. If we see on the images like B and C, we found an cerebral hemisphere anormal with an small periventricular frontal cyst, and in the E and F we found a periventricular cyst that as we see on this slide. Next one, please. Jen, thank you. Next one, yeah. Next, please, Jen. It's not changing. Okay, sure. And these are some examples of Dandy Walker malformations. For example, on the letter E and H, we found a ventriculomegaly, and we found too a cyst in, or a cerebellar cyst or infratentorial cyst that are one of the many variations of the malformations in Dandy Walker, and we must choose what kind of shunt we're going to use. And this is very important because if we just try to put a shunt at the supratentorial level, we are just gonna try to evacuate this cerebrospinal fluid at that level. And if we see these patients are gonna have a complication or an early complication associated with it, like mechanical complications. Next one, please. So I put this because it's very important to know in infants or children, according to the age, what kind of pressure they are gonna have in this cerebrospinal fluid, and we're gonna use this to try to put the shunt or the ventriculoperitoneal shunt according with this. This is very important in this kind of patients. Next one, please. This is just an example of normal human plasma and the lumbar cerebrospinal fluid components. This is not so important. Next one, please. And this is important too, like the pressure. We found the level of protein in the cerebrospinal fluid according to the age of these patients are gonna, well, it's gonna have many variations according with it. Like we see on the 0 to 30 days, we're gonna found to 20 to 150 milligrams over deciliter proteins. And this is, how can I say it? This is very different from an adult, because if we found this in an adult, we can suspect that he had an infection, and in this kind of patients, it's normal. So we must consider this if we think in complications. Next one, please. Next. So the procedure according to the valve and their indications. Next one. Okay, this. According to, no, back to the other one, please.
Please talk about procedure, no?
Okay. We have this procedure and valve according to the type of hydrocephalus. We must consider this because in this kind of patients, like I said before, they have many variations and malformations. So if we are thinking in a standard size ventriculars, we're gonna use a programmable or medium pressure valve. And if we found some patients that are premature and the newborn, we can use a programmable set with a low pressure or a low pressure valve and a small counter valve. And in the large ventricles or chronic hydrocephalus, like in an adult patient, we can use a programmable or a flow regulated. And when we had one of these complications like the overdrainage, we can use a programmable flow regulated gravity valve or an anti-siphon devices. And when we had an obstructive hydrocephalus, we can use another kind of procedures, as we know, like endoscopic third ventriculostomy or another kind of cerebrospinal fluid shunt. And when we have a multiloculated hydrocephalus with an arachnoid cyst or a foreventricular trap, we can use the neuroendoscopy and another DVP with one or two, like I said in the patients with Dandy Walker, in a letter Y. Next one, please.
Sir, excuse me, sir. In pediatric patients with a large skull.
Do you see that okay? Is that the slide, correct slide?
Yeah.
Okay.
Yeah, the next one, please.
Pediatric patients with large skull, where do you place the bar hole during shunting?
We can use one single borehole for that. We can use the classic position when we put this shunt at parietal posterior. At least I like that because we put one catheter in at supratentorial level and another one connected to the valve or to the valve, and this another catheter is gonna.
My question is regarding the position of the bar hole, sir. Where do we exactly put the bar hole? Because pediatric patients, we get big skull with large hydrocephalus, big skull. So where exactly our bar hole should be there during tapping? It should be like Apuzzo's point or something like that.
I couldn't hear the question. Can you repeat?
Okay. Well, you know, why don't we get to the questions after the presentation? Why don't you continue, Omar? Okay.
Okay.
Just continue. We'll get to questions.
Yeah,
after.
that's fine.
Okay.
Okay, let's continue. So the causes of the cerebral spinal fluid shunt complications. Next one, please. Well, we have the most common complication is the mechanical complications. We can find it in proximal or distal at the catheter or sometimes there are fractures or catheter migration. We found this kind of complications in 8 to 64%. The second one is the functional complications, to 3 to 50%. Local infection in 3 to 12%, and the intra-abdominal complications like cysts and at the abdominal cavity in 1 to 24%, and the intracranial hemorrhage like intraventricular or sometimes complications associated like the presentation of a subdural hematoma in 4% and epilepsy in 20 to 30%. Next one, please. Next one. Would you kindly change it, John? Thank you. So the symptoms and the signs that we are gonna find in these patients are too many. We found, for example, a headache associated with fever, nausea with collection along the shunt tract. You're gonna see an imagery of this. We found two feeding problems, lethargy, or we can use another scales to see this kind of changes. Abdominal pain, diarrhea or constipation, and sometimes are associated with a palpable intra-abdominal mass, and respiratory symptoms, which are one of the most important symptoms in these patients. And the most important is dyspnea, because it's an indirect symptom or a sign of intracranial hypertension. Next one, please. Will you change the slide, please, John? Thank you. So in these images, we can see in this child skin rating along all the thoracic wall. Well, this is an indirect sign of an infection along the tract of this shunt. And in the letter B, we found another patient with all this subcutaneous accumulation of fluid. It's different from the previous photograph because we found it like in white. The tract is very different along this thoracic. Next one, please.
Oh, no, next slide. We try another one. Okay, there we go. Is that one? Is that the right one?
Yeah, sorry.
Sorry.
Yeah. Well, we have one more time this kind of
forward
type of drainage system. We found another like the ventriculopleural, and we found these kind of complications associated with this. Next slide, please. And we know that there are another kind of shunts like the lumboperitoneal who have these complications like failure in recognizing complications over drainage, or the ventricular gallbladder, which is very rare to find patient with it. And the most common, the subperitoneal and the cystoperitoneal shunts, who had a lot of complications like cortical jam, oculated hydrocephalus with wrong position when we try to put the shunt on the posterior fossa drainages, like in the patients with Dudley Walker, when we can use multiple complications associated. Next slide, please. Next slide.
Is that the right one?
The next, please.
The next one?
Yeah.
Okay.
We have, that's fine, that's fine. This is good. Okay, next one. Okay, another one. So in these photographs, we see in the left superior part of the slide, we found a CT scan with a bone window when we see this partial intracranial migration, and on the other photograph we found this image of well, when we are in surgery, we found this valve part grows around it. Next slide, please. Next slide. The next one, John. John.
Okay. Yeah.
Thank you.
Okay.
That's fine. That's fine. Don't worry.
Okay.
On this photograph, we see a distal catheter dysfunction with a cirrus, occurring with a due infection on sorry. So we found these kind of infections as associated with in the distal catheter. So we found sometimes cysts that this abdominal, we must think in another kind of shunt, or sometimes we must use antibiotics and another kind of stuff to try to treat this, but it's very, very hard. And sometimes the patients had a bad prognostic. Next one, please. Next slide, please, John. So in this photograph, we see a patient with a shunt failure. This is a mechanical failure when we found subcutaneous cerebrospinal fluid accumulation, like we see in the arrows, along all the shunt tract. Next one. So in conclusion, next one, please, Jen. Okay, we see that the most frequent complication of cerebrospinal shunting are the mechanical, and then the infections, and finally the functional. Next one, please. So it's not always easy to distinguish these kind of complications because we are talking about pediatrics. So the causing shunt dysfunction will be very hard sometimes to distinguish from another, for example, mechanical infection or functional. Next one. So another kind of complications that may present with a variety of symptoms and signs that we must know, or we must see in these patients, we must ask to the parents or sometimes to get to the final diagnosis. And next one. Next. Okay. The clinical manifestations vary according to the patient's age and the etiology, like we talked in the first slides, and the etiology of hydrocephalus, and the cavity of cerebrospinal fluid drainage, and the type of valve or the shunt that we are going to use. Next, please. And next. So, the final conclusion, we see that the appropriate knowledge of the mechanism that may contribute to in the production of the cerebrospinal fluid shunt failure, preventive measures to avoid them, and together with forthcoming will doubtless contribute to decrease the number and the severity of the complications. So this is something that we must think, or always that we see these kind of patients, or we think well. Next one. Well, and finally we have the references. So that's for these complications in this slide, and that's all, John. This is the final slide. We haven't, yeah. So one more time, I'm sorry for delayed and for these problems with my web. And
yeah, you don't. Thank you very much. You don't have to apologize for the technology, because we're going ahead. We're just pushing ahead, because technology will get better, and we'll get, you know, the power of the internet. I'm familiar with Mexico City. The internet is very, very challenging in Mexico City. I know about it. So I'm sure some panelists have some comments or questions. Don't worry. You just had the courage to do that. I'm glad. I'm glad you got through it.
Thank you.
Any questions or comments for Omar?
Hello, Dr. Valdez. I'm Natalie Gomsi.
Hi.
Okay, my question goes to the shunting with the double valve. And you said why? How do you do that? I've never seen it done. So why is it that it is particular for the treatments of in case of, you said, I think I heard word dandy worker, and why is it that it's used mainly for that? Then the second question goes to, I once read on ventriculostomy usually associated with the cauterization of choroid plexus as ameliorating the outcome of patients, having a better outcome. What do you think about that technique, actually?
That technique, it's very useful when we have too many complications in the same patient, like infections, or when we had, for example, cyst in the abdominal cavity, and we don't want to put another shunt at the thoracic level or the ventricular trail shunt. We must consider that kind of procedure that you mentioned. Even if the patient had an infection, we must consider it, because they can have a good outcome in the future, or maybe not. We have another percentage of failure, like 50% of failure with it, but sometimes it's the best decision to make that kind of procedure. And that's all.
Burhole.
Okay, more comments, questions?
Location of burhole in case of large hydrocephalus. Where do you want to put the burhole with big heads? Any measurements, any such as that? Where do you want to exactly place the burhole when you are putting a shunt in pediatric patient?
Did you hear that question okay, Omar?
No.
No, I know. Oh, no, okay. Redmayne, we're having a hard time understanding. Could you text the question in the chat? We're
I
just
think
having
he
a
was
hard time.
talking about are there measurements for the burhole that we do for doing a shunting.
Yes.
The boreholes.
Yeah, the borehole. Well, the position of the borehole will be very hard to precision. We must first see what kind of patient we have. According to the age of the patient, we're gonna think about this borehole. Why? Because if we had a newborn, we know that the fontanelles are not united, and if we had another patient, for example, a 5th year or 7th year patient, we can use a parietal posterior borehole, for example, but in newborns, we can put this borehole. Sometimes I used to put it at the level where the parietal posterior sometimes, or we must use the CT scan to try to put this shunt. It's a very hard question, I know, because in newborns it's very difficult to put this borehole, and sometimes there are many variations of the procedure, and if we are thinking that we are gonna put another shunt connected with it, we can think to put another borehole at the occipital level. It's a very hard question, but I can send to you an article if you want, or I can explain myself with an image for you. If you wanna text me, I can send you the information, because it's very hard to try to explain right now, because there are many variations of that borehole according to the age of the patient. Is that okay for you?
Okay.
Yeah, put your email in the chat box, and I'll see that Omar gets it, okay? Anyone anyone can put their email in there so that I can send it to Omar. Okay.
Dr. Valdez, I've got another question, please.
Go ahead, Natalie.
How do we prevent most of those complications? What are the methods that we use to prevent them during the surgery or before the surgery, and even after it?
First, we must type we are gonna treat, and if we found in the CT scan or the MRI some kind of malformation associated, we must first see the patient had another infratentorial malformation. We can use 2 variants of the shunt. To avoid that kind of complications, we must think in this first, so we can avoid the mechanical complications. Once that we found the most according shunt to put on this kind of patient and the pressure, we can avoid the mechanical complications. the infections are sometimes hard to prevent because there are a lot of articles that mention the use of the shunts with antibiotics, or sometimes the use of the prophylactic antibiotics during the surgery and after that. But sometimes it's very hard even with it to avoid infections because we are talking about of the immune system of these patients are very primitive, and infections sometimes can present. Or if we use only one equip to the same patient or the same surgeon, we can avoid sometimes infections, but it's very hard to avoid some of these complications.
Okay, very good. Dr. Gabullo, do you have any comments for Omar or questions?
Okay, thank you so much for that beautiful presentation. I just want to know if you came across the paper written by Professor Kalangu about towards zero infection.
Sorry, what?
Yeah, he wants to know if you ever saw the paper by Dr. Kazadi. Dr. Kazadi, is that who wrote it? The paper, who was it by?
What paper? Sorry.
Yeah, don't worry.
I have some troubles.
Yeah, Dr. Gabullo, could you mention that paper again, please, that you mentioned?
Yes, I'm saying if he came across the paper written by Professor Kazadi Kalangu towards zero infection of shunt.
Right, Dr. Kazadi, zero infection of the shunt.
Okay. Yeah, but they use the same personnel or the same doctors and residents equipped to treat these patients. And if we can have this in every hospital, we can avoid the infections, but sometimes it's very hard to do it because we must have the same nurse, the same doctor, the same surgeon at the same time to avoid the infections, and it's very hard to do it. And we must have the antibiotics and all the stuff in the same place. We, at least in my country, it's very hard to do it. So we just try to avoid the infections. For example, we use the same resident to treat the same patient and the other one and the other one and the other one. But then he get that or he avoid that complication just because he used the same equipment, the same doctors at the same time. It's very hard to do it.
Dr. Omar, do you test the shunt before placing it?
What?
Once again, Dr.
Gabullo? Do you usually test the shunt? You know, others are taking normal saline with a syringe. You test the shunt if it's permeable before you place it. Do you also do that?
Yeah, we used to test the shunt. Yeah, we used to do that, but we can get more infections if we do that. I used to prove the shunt only in adults, not in childs. I used to do that just in adults, not in these kind of patients, because like I said before, their immune system is very primitive and it's different from an adult patient. So I don't do that in these kind of patients.
Okay, very good.
Is that okay?
Hey, John,
Or...
on that note.
Go ahead. We can hardly hear you.
I couldn't hear that.
Which one? Try again. Whoever asked that question.
Or you can text it.
Yeah, Kennedy. I don't think we'll get. It's going to work. It's going to work. You can text the question. Okay. Redme refuses to send me his email, so I can't send you the information. Redme. Okay, Rahul, you have any remarks or questions?
Actually, Kennedy posted on the that.
Go ahead.
Is
Go
there
ahead.
is there any particular reason why the male sex is more predisposed than the female gender?
In general, I had this issue because in the male sex will or are predisposed to have more complications or more malformations associated, but there's no single reason that can explain why the male sex is more predisposed to this kind of complications.
Okay.
It's just because we found more malformations and they are predisposed to get another surgery to correct a mechanical complication, for example, and they will be predisposed to get an infection site.
Okay, more comments or questions?
His second question.
I'm sorry, you still explaining it?
Can Kennedy ask the second question? He wanted to ask if he flushes the shunt system with antibiotics.
We tried that a few years ago, but we see that our patients, at least in our hospital, had the same predisposed to get an infection with or without the use of the antibiotic or the shunt impregnated with an antibiotic. For us, it's the same predisposed to get an infection with or without the antibiotic.
Okay, more comments. Hello, Roberto, welcome. You can't, late arrival. Musindo, welcome. Welcome, Roberto. Musindo, any comments or questions? Musindo is a common participant. He's from Zimbabwe, I believe. Okay, perhaps he stepped away. Dr. Manzer.
He's from Mozambique.
Mozambique, yeah, I always say Zimbabwe, Mozambique. Hello, Nihufar, I'm sorry to get your name wrong. Nilufar Tureva. Welcome. Okay, I guess Kennedy has a lot of questions. Okay, I think he has another question. Any more questions? And
yeah.
Go ahead, Kennedy. Loculated.
More question. Loculated cyst in the abdomen. How do you go about it?
Very good.
I've seen just one patient with that complication in 2 years. We treat this patient at first thinking in ventriculoatrial shunt, but we must think that this cyst sometimes it's contaminated or there's an infection on this side, so we can't put another shunt for the risk of infection in another place. And the antibiotic that we use sometimes, it's according to the site of the infection, and we we get the help of an infectology. So, and there's not a single antibiotic that we can use, but we can sometimes use vancomycin or another one to avoid a site of infection with with a gram-positive. So what about antibiotic impregnate? These kind of shunts that are impregnate with antibiotic are very expensive sometimes for our population or our country, and we don't use that, or we don't use this kind of shunts. Like I said before, we found many articles where there's, for example, we can see that a serious infection, but it's very hard to get that. Honestly, I doubt that we can get that serious infection in too many places or hospitals. We must have the same structure and the same equip of surgeons to get that. It's very hard to do it, or at least I can't get to that zero infection in our country. It's very hard to do it. We have few patients with an infection site or an central nervous infection associated with this shunt, the zero infection yet. It's very hard to reproduce that.
Well, Omar, I believe Dr. Cabullo had a relevant article that he wants to show you about Dr. Kazani's. Yeah. Go ahead, Dr.
Yeah,
Cabullo.
I saw it.
Oh, you did? Oh, you did. Okay. Okay. I thought you wanted to discuss. Did you want to discuss something about that paper, Dr. Cabullo? Because I know she put it up there on the board there.
The other one, antibiotics used. Okay.
Yeah,
so I didn't want to discuss about it. I wanted just him to see this paper because the previous one was by Professor Shooks, Maurice Shooks from Hôpital Latimon in Marseille, in France. Then the next one was by Professor Kalango, because Professor Shooks said you should reduce the number of patients, of whatever surgeons, and you don't need to get a scrub nest when you are operating you are doing the VP shunt to reduce the rate of infection. And also you don't test the shunt according to Professor Shooks. But Prof. Kalango also is using betadine every time you are operating. Betadine, and we did that multi-center study, which showed the lowest rate of infection in the world. So I think the paper was very nice. You can go through it, you will see something nice.
You know, Joanna has some remarks. I don't know if you want to mention them, Joanna, or you want me to. Do you want to mention them, Joanna, from Finland?
Yeah, hi guys. I've only done VP shunting for adults, so that's why this is quite interesting aspect to see. Also for pediatric patients, I was just wondering that in case of meningitis or peritonitis, how fast do you guys remove the shunt? How is it done in your countries? In Finland, it's usually so that the first surgeon basically shortens it as much as possible, and the neurosurgeon then maintains the cranial part. And antibiotics are done or used systematically mostly. Vancomycin and wide spectrum. How is it?
We use sometimes the systematic vancomycin just in one doses, or we use this antibiotic just in patients with the infection already. We don't use this vancomycin like in prophylaxis, because we can get sometimes a resistant infection, so that's why we don't use the vancomycin in first line. We can use just
in case of meningitis or peritonitis. That was the only in those cases.
We can use vancomycin in meningitis, and when we have a cyst in the abdominal cavity, we can use sometimes to, well, the another antibiotics, I forgot the name, Jesus. It's sometimes meropenem or ertapenem.
Okay.
We can use many of those, but we used to prefer to go to the infectologist and present the case, and then he used to treat the infection appropriately. So we prefer to act before to put an antibiotic, to go to the infectologist to get a better treatment with these antibiotics.
Okay, there's a remark by Nilofar Tur-Eva. Do you want to read that remark, Nilofar, yourself?
Yes, if you can hear me. I just remember.
Okay, go ahead.
Okay. I just remember once Professor Chokes came to Uzbekistan and he gave his lecture and he was talking like about these shunting systems. He said there is no necessity of getting the expensive kind of shunts, Medtronic type of. We just at that time we used Indian ones. So he said it's okay to use it because it's evidence also showed that we need to change the shunt anyway after, like not anyway, but 50% after 2 years. So that would be anyway the shunt malfunctioning. And the second remark that he said is, of course, we need to use double glove in order to put the shunt. So when we were, it was just in his lecture, I do remember that.
Thank you.
Hello, everybody.
Okay. Go ahead, Zolo.
Okay, I have a question. I don't know if it's appropriate, but I wish to know, for example, assuming that there's a patient who has a shunt in place, a ventricular peritoneal shunt in place, and the patient gets a peritonitis, like to say bacterial peritonitis. Do we necessarily? I mean, what is the protocol here in this case? Are we going to remove the shunt of the patient, change it?
No.
What do you do in that case?
You can put a ventriculostomy in the other hemisphere, for example, to put the ventriculostomy at the precoronal side and on the other side of the place where you find this complication. We don't use to remove the shunt because we can get another complication like an intraventricular hemorrhage. That's why we prefer to use a ventriculostomy to treat the infection, and we after that we'll consider to remove the other shunt.
Sorry, I have a question, Doctor. I have a question to Zolo. Zolo, what do you mean that the peritonitis, is it due to technique while placing the shunt, or it's just a peritonitis due to other things? The cause is other than the shunt.
We can remove the distal shunt. We can remove it. We can remove the distal shunt, or we sometimes improve. We used to cut the distal catheter, and we closed the other portion of this catheter, and then collocate the ventriculostomy, because we cannot place another shunt, or for example, an a ventricular trailer shunt. We cannot put this because we have not just peritonitis, we have a systemic infection, and we can get one more time another complication, for example, endocarditis.
Okay, more comments or remarks from anybody? Eminata, You told me before, if I have a question, I'll ask it. But do you have any remarks or anything? Let me unmute your left phone. Hold on. I know that mute button's tricky. You really got to stay on top of it. Go ahead. Go ahead.
Indeed, if I do have a question, I'll ask it. I'm enjoying the conversation and the discussion, and especially the mention of Prof. Kalangu's paper, which we are familiar with, and I'm glad it was brought up as well. It's a very useful paper. Thank you.
Thank you, Anna.
Thank you too.
Okay, any other comments or questions? Okay, very good. Thank you for being patient with the technology, Omar, because as you can see,
yeah.
You know, it's a little choppy and the sound, but that's okay. It's better that you went through and you did it. I think it's better than just.
It will be better.
Well, we'll all get better. I'll get better. All these guys will get better. Sometimes I talk for a few minutes and then I realize my mute button's on and no one can hear me. So anyways, so thanks everybody for coming. I'm just going to stop this and then we're going to start the next lecture, okay?